Okay, welcome everyone to the final session of the forum. So this is, I've lost my title. Sorry, ignore me. Welcome. So the presenters of this session will overview complex presentations associated with hepatitis C and implications on their management. Our first session presenter is Dr. Sam Elliott, who's a specialist general practitioner at Riverside Medical and also ASHM board member. Sam will be providing a case study presentation on hepatitis C and HIV co-infection. Thanks, Sam.
Thanks, Bianca. This is a case study presentation, and I would encourage, there's a couple of slides where I ask quite a lot of questions, and feel free to respond in the discussion forum tab that you've got there, and I'll take questions from anyone other than Nada. So basically the case discussion is a Mr. JM. He's a man who presented to the practice. He was 58 years of age and he just relocated from Melbourne to Adelaide. His past medical history, he had high blood pressure, he had HIV, that was diagnosed in 1998. He'd had syphilis treated before and he had cholelithiasis in addition to a few other health issues. This is his medication list, which looks pretty long, but it's not that complex. He's got a blood pressure tablet, he's got a proton pump inhibitor, he's got antidepressants, and he's got his antiretrovirals. So he was on a drug called Genvoya, which has got elvitegravir, which is an integrase inhibitor, cobicistat, which is a booster, emtricitabine, which is a backbone nucleoside used in HIV, and tenofovir, alafenamide, which is also a common drug used in HIV. So he asked for a HIV review, and that was his primary reason for presenting, but he also wanted me to give him an STI check at the same time because he'd noticed these moist perianal lesions. So his sexual history was that he was preferred to have sex with males, but he also had some history of heterosexual activity. His HIV had been well controlled since his diagnosis, and he'd started therapy not long after diagnosis. I took some routine HIV bloods, did an STI testing on him, including swabs of the perianal lesions, and these are his results. So his HIV viral load was less than 20 copies per mil, which is fantastic. He's got great virological suppression of his HIV. His CD4 count was 810 with 47%, which is also fantastic, indicating very good immune function. And his full blood count was normal, so his platelet count was normal. But with his LFTs, his GFR surprisingly was only 42, which there was no renal impairment in his past medical history, but he clearly is impaired, or appears to be. And he had these raised liver functions, with in particular his GGT was 123, his AST was 521, and his ALT was 660, but with a normal bilirubin. So on finding these, I rang his previous GP in Melbourne, and after some difficulty getting onto his previous GP, I finally managed to discuss his previous LFTs, and in fact, his LFTs from 6 months previously were considered normal. So his throat, anal and urine all came back negative for chlamydia and gonorrhea. His lesion swab, however, came back HSV1 positive, so he had genital herpes. His syphilis treponemin antibodies were positive, and his RPR or titer was 1, which is very low. He was commenced on valacyclovir for the herpes. And then he was asked further questions because I wanted to assess what was going on with his liver, and he acknowledged he was involved in chemsex where he'd use amphetamines intravenously, but these were injected by his sexual partner or whoever the sexual partner was, but only with clean needles. And he denied any consumption of alcohol, and he was a non-smoker. So based on his raised liver functions, I wonder if anyone else wants to just write into the discussion forum there what additional tests might be required, given that he had normal liver function 6 months ago and he now has these what would appear to be acutely raised liver functions. what would you do? So maybe I should ask Nada. So no one's commenting, but I think most, well, certainly everyone who's presented today, I think would be aware that you need to do hepatitis serology and you need to do hepatitis A, B, and C. So hepatitis A, definitely not uncommon in the MSM population. And certainly at the time this gentleman presented to the practice, there was a mini outbreak of hepatitis A in Melbourne. So that would have been possible. Hepatitis B, clearly, once again, this is also common in the MSM community. And then hepatitis C serology. Liver ultrasound, because he had a history of cholelithiasis, plus liver ultrasound sounds like a good idea. You could consider doing a syphilis PCR swab on the perianal lesions, and in fact I did. And then because of his renal impairment, and because, you know, we're possibly going to treat him for something here, I did his urinary albumin to creatinine to look at his glomerular function, and did a urinary protein to creatinine to look at his function of his tubular function, which is more what gets disturbed by tenofovir, which is one of the drugs he's on. So his results came back, his liver ultrasound, he had multiple gallstones, but the gallbladder didn't appear to be thickened. He had normal portal veins, no splenomegaly, and he had normal kidneys. His hepatitis A was IgG positive, but IgM negative. His hepatitis B surface antibody was positive, but his core antibody was negative, and his hepatitis C was positive. Now, when I requested this test, I was pretty sure it was going to be hep C, so I asked for reflexive testing or reflex testing. So the lab went on to test his RNA, and that was also positive, so his hepatitis C RNA, and they did his genotype, was 1A, and he had a viral load of 330, which, as you know, we don't really need all that these days, but this was about 18 months, 2 years ago. But nonetheless, not an exceptionally high viral load. His syphilis swab was negative, indicating probably he just had past treated syphilis, but also could be early syphilis, so we still need to watch for that. But his urinary ACR and PCR, surprisingly, were both completely normal. He had no leakage of either low or high molecular weight proteins. So that was interesting. So
sorry, Sam, we just have a comment in the discussion forum from Bernadine.
yeah.
Would we also do the liver and auto antibodies?
Yeah, look, I have to be honest, when I get a new patient with raised liver functions, I generally would do autoantibodies. Because this was an acute, sudden, you know, and his previous ones were negative, and because I was already presupposing he had hepatitis C, no, I didn't do them. But that's a very good point. And it's part of, as I gave in my previous presentation, I've got a liver panel, which I just click the button, liver panel, and all the liver autoantibodies are in there. But I would probably do that more for someone with chronic liver disease where you've got no idea, it could be anything. Whereas this was like an acute liver dysfunction. So I was more in, you know, I was more in along the lines of either an acute gallbladder problem or, you know, viral hepatitis. So that's why, that explains why I didn't do it. But yeah, be interested to know what others think about that. But yeah, and she's also asked about tumour markers. Similarly, he had no evidence of prior liver disease. So no, I probably wouldn't do liver markers, tumour markers straight away either. But yeah. So I'll move on to the next one, which is the hepatitis C. Interestingly, shortly after coming to see me, he was admitted to the Royal Adelaide Hospital with psychosis, where he was admitted for quite an extensive period of time for treatment. And obviously I had not known him previously, so was not expecting that. But he came back to the practice 5 months later. So at this stage, by the time he's come back, it's at least 6 months post his rise in liver functions. And interestingly, his GFR had gone up to 59, so that was a little bit more respectable from a renal function perspective. And his GGT was now 127, but his AST had dropped to 63 and his ALT to 88. So based on that, I made the assumption that he'd had acute hepatitis C infection and that now he was entering into the chronic hepatitis C phase of the infection. So I talked to him about treatment for hepatitis C, and he expressed a lot of reluctance, and yeah, his mental health was a really big issue, and I'm sure we're all pretty familiar with that when it comes to managing hepatitis C. But after a reasonable discussion, the consensus was we would start therapy. So we started some antiviral therapy, and we followed him up at 4 weeks. And at that point, he had no side effects, and he said he was feeling much better, had more energy, and his head was feeling much clearer. So at that point, I repeated his LFTs, and his ALP was now normal. His GGT was down to 97, but in particular, his AST was now 37 and the ALT 45, which is what I tend to find at 4 weeks. There's usually a halving of the AST and the ALT, and that's roughly what happened with this gentleman. So more questions for the group, and that's great. Thank you for those who have put in some questions or discussion in the forum chat box there. So what are some of the considerations that we would consider here with someone who's HIV and hepatitis C co-infected? Is it safe? When should we start treatment in such a person? Is his severe mental health a contraindication to HCV therapy? And if he was hepatitis B surface antibody negative, would this change management? Aaron has put a message in saying it's interesting that the hospital didn't treat his hepatitis C while admitted. I'm not surprised at all, but psychiatrists aren't usually very good at doing that. And it's amazing how many people are in hospital and they don't coordinate care. They're usually under one team, and often the other team doesn't get involved. Ben Cowie has said that's pretty expected, actually. More of a PBS issue with prescribing in the hospital. That's an interesting point. Thanks, Ben. Anyone else got any other comments about this? So I'll move on. So what the treatment I did use was sofosbuvir and velpatasvir for 12 weeks. He had no complications or side effects, and his SVR12 was confirmed at 12 weeks post completion of therapy. So some of the real considerations with co-infected patients is that by far the biggest when it comes to, and these pretty much across the board with all patients. So that's why I think this is pertinent to every patient, not just HIV patients. And that's drug-drug interactions. When it comes to HIV, the big ones are the protease inhibitors and the the NNRTIs, which are the non-nucleotide reverse transcriptase inhibitors that were used a lot more commonly in HIV, probably not used as much these days, but yet they are. Actually, Ben's also put a question in, did his syphilis serology get followed up also? And yeah, I did repeat his syphilis serology, and his RPR remained at 1, indicating that it's almost definitely just a previously treated infection. But the most important thing with the drug-drug interaction is, and I think it was Roshan that sort of talked about that in his earlier talk today, and that's about using the Liverpool hepatitis drug interaction database. Can't speak more highly of that database. There's almost nothing that you won't get on there, and it provides much, much more useful information than your clinical software or MIMS. So you get really good indicators. Yeah, consider the degree of renal impairment and or liver impairment. So, in this case, initially it looked like his renal impairment was, fairly moderately severe, but on follow-up it wasn't really too bad, sitting at 59 GFR. And his liver impairment, he had normal protein levels, he had normal bilirubin, and, as we saw, his spleen wasn't enlarged. And I think the really big thing is, hepatitis B. So core antibodies are really common in HIV positive patients. So when you're doing the hepatitis B serology, you need to make sure the lab includes the core antibodies along with the hepatitis B surface antigens. And you need to be aware of hepatitis B flares. And Ben's going to talk about this, so I won't discuss that any further. The main thing with HIV patients, though, is there was a recent paper presented at CROI only 1 month ago, or 2 months now, and that was sort of looking at 46 or 460 patients who were treated, most of whom were HIV, hepatitis C co-infected patients. And they found that really you just had to follow the standard care for HCV therapy, and they all had a very good outcome with the same sort of, side effect profile as those without HIV. So really, just standard care is what you need to do, but you definitely need to look at the drug-drug interactions. The only other consideration is if someone really wasn't well controlled, that is if they were pretty immune compromised with a CD4 count of less than 200, you probably would want to seek specialist input. And clearly, if they're not on antiretrovirals, that's another factor that you would need to look at. So the next lot of slides I've got, they're a bit busy, but in essence, these are from ASHM, but they just show the interactions between the hepatitis C and HIV drugs. So when you look at the backbone for nearly all HIV therapy, most patients are on NRTIs, which are the nucleoside or nucleotide reverse transcriptase inhibitors. And you can see there's a tick there with virtually all of them. So whether you're using velpatasvir or you're using pibrentasvir, doesn't really matter what you're using. They get along well with the backbone of HIV drugs. But once you move into the protease inhibitors and the NNRTIs, you can see an awful lot of crosses there. So that's a cross is not like, reduced dose, take at different times. They're absolute contraindications. You cannot mix them. So there's a lot to think about there. And then when you move on to integrase inhibitors, which are probably the more commonly used drugs along with your nuclear NRTIs, most of those get a tick. So by and large, a lot of, even though it looks pretty messy, most of them do get along well as long as they're not on a protease inhibitor or one of the old NNRTIs. So the easiest way to do it is not to go back to charts like that, but just go straight onto the Liverpool Hep Drug Interactions website. And this is a website you should be using for all patients, really. So they don't need to be HIV patients. But so what you do is you put the hepatitis B drugs in. So if you're going to use either Mavorite or you're going to use, your SOF with, let's say, velpatasvir, you just put those in as your hepatitis B drug. And then in the second little section there, you put in your other drugs, such as, in this case, proton pump inhibitors. And you can put every drug in. So you put the whole lot in all at once. You don't have to do it individually. And then what you get is you'll get all sorts of reports. But what I did with this gentleman is just out of interest. You put in, HIV drugs along with protease inhibitors, and you can see it's just don't do it. But then when you move over to velpatasvir, it's fine with all the protease inhibitors virtually. However, if you've got a patient who's failed treatment and you're putting them on, the triple therapy with, voxilaprevir in there, then, once again, you can see lots of reds. So in essence, you just need to look at the hepatitis C drug you're using. And if it's got protease inhibitors in there, which is the, Previr on the end, or PREVIR, if you've got a drug that's got that on the end, then you need to be careful mixing it with other protease inhibitors. So this gentleman, this is the report we got. It doesn't come out that well there. But in essence, after all that, the only real significant interaction we get is with the proton pump inhibitor. So no problems with the HIV drugs, no problems with his antidepressants, with his diuretic, with his A2 inhibitor. They're all fine. So you get the green light and you just import that into the patient's file, which is just a good backup to say, look, I followed a protocol here and I checked, and yep, it said everything was fine. So the only thing we had to do was obviously separate his proton pump inhibitor, the timing at which he took that from when he took his velpatasvir, and just you need to minimize it to a dose equivalent to omeprazole 20 milligrams, which is what we did. So in summary, and a lot of this really does also go through, similar sort of, sorry, someone just asked me a question. It was Nada. Just looking through those interactions, notice that SOF and the dipasvir might be a better option in some situations. is that still available? So yeah, you can still do the Harvoni. And look, I've still used Harvoni, and I've still used the old the MS the other drugs as well. So whether it be Grazeprevir, sometimes you've got a renally impaired patient, significantly renal impairment, where you may want to use that. So you can still use the old drugs, and there is those niches, but I have to be honest, there's not that many occasions that I've found where you really need to. But yeah, I have still used Harvoni. So overall, I mean, basically all patients who are co-infected with HCV, HIV should be treated irrespective of the CD4 count. But the most important factor is, as we've said, is the drug-drug interactions. And I think that goes with all of our patients. So many of our patients are on quite a lot of other drugs. And so you should definitely be making good use of that Liverpool database. And they're no different to any, the co-infected patients are no different to anyone else. You always got to look at the liver fibrosis, and in particular to see who needs follow-up going forth, looking at hepatocellular carcinoma surveillance and liver disease surveillance. And absolutely don't forget to do a hepatitis B virus assessment. And if they have got evidence of past or current infection, you will have to manage that differently, and you probably want to get an expert like Ben Cowie involved. And I won't go into what you would do differently. But overall, as long as the patient's well controlled on their antiretrovirals, which is 90% of all HIV patients these days, they can just receive the standard of care for HCV therapy. So yeah, thank you. And so I think Ben's next.
Thank you, Sam, and for sharing your case study discussion. If there's any further questions for Sam, if you enter them into the live Q&A section, rather than the discussion forum, we'll add them after Ben's presentation. So we will move on to Ben. So obviously our last presenter for the forum is Professor Ben Cowie, Director of the World Health Organization Collaborating Centre for Viral Hepatitis. Ben will be providing an overview of hepatitis B and C epidemiology with considerations and implications for general practice. Thank you, Ben.
Thanks, Bianca, and it's a great pleasure to be here today. So thank you for the invitation to do so, to both yourself and Asham, and obviously Nada, who dobbed me in for it in the first instance. So before we get started, I don't know if you've had other speakers this morning from Melbourne, but I'd like to acknowledge that I'm currently in the lands of the Bunurong people of the Kulin Nation, and acknowledge the elders past, present and emerging from the lands where I live. So look, I will work through some slides to present. Really happy to look at the discussion as well, so I'll try and keep an eye on that as well, but I'll start sharing my slides now. So bear with me a moment, colleagues. Alrighty. So that should be presenting now. So hepatitis B and C co-infection, or before I get going, I would like to acknowledge people living with viral hepatitis and the funding support. And I'd like to acknowledge that I have no conflicts of interest with relation to healthcare related industry. So co-infection with hepatitis B and hepatitis C is an area that I think some people find a little confusing and a little complicated and a little scary for some people. I think the idea of Hep B reactivation sort of coming out of the blue and causing problems for patients is something that particularly after the FDA put some box warnings on DAAs back in 2016, did cause a bit of concern, particularly, and I think Sam picked up on this point about it's not just about people who are surface antigen positive, but those who have had past exposure to hepatitis B, core antibody positive. So we'll work through some of that and then come up with some practical recommendations for how we manage this. So in terms of the epidemiology of chronic hepatitis B and hepatitis C co-infection, so clearly there are shared modes of acquisition. We know that for the case of hepatitis C, it's most commonly acquired through parenteral exposure and amongst patients here in Australia, most commonly through injecting drug use. That clearly has overlapping patterns of transmission with hepatitis B. However, there are different patterns of co-infection in populations, particularly where hepatitis B is endemic, because as we know, if someone's exposed to hepatitis B as an adult, then 95% of those people will clear their infection. Whereas if someone's exposed as an infant, certainly in the pre-vaccine era, 90% of those people will go on to chronic infection. So you can see quite a significant difference in the prevalence of co-infection in populations that are endemic for hepatitis B. However, whilst robust estimates remain lacking, it's been estimated that up to 5% of people living in Australia with chronic hepatitis C may be co-infected and surface antigen positive with hepatitis B. A lot more have serological evidence of past exposure for those same reasons of overlapping epidemiology. So why do we care? The natural history of co-infection with hepatitis B and hepatitis C is somewhat different. We know that there's more rapid progression to advanced liver disease in the setting of co-infection. We also have good evidence that there's a higher incidence of hepatocellular carcinoma amongst co-infected individuals. It's been shown here, including in Australia from some of the linkage studies that have been done by the Kirby Institute over a number of years, that there's a substantially increased risk of liver-related mortality in co-infected individuals than is the case with either hepatitis B or hepatitis C monoinfection. One point which relates to the concern around reactivation is that there does appear to be viral interference between the hepatitis B and the hepatitis C. So what you will usually see is one of the viruses being predominant, and that's typically hepatitis C. You'll see that the hepatitis B replication is often suppressed in the setting of hepatitis C. And this is why the concern about reactivation is there, because the idea is if we come through with direct-acting antivirals and very rapidly and effectively reduce someone's hepatitis C replication, that their hepatitis B can then reactivate. And that really is that concern, which has been a little different in the DAA era, because in the past, when we were treating people with pegylated interferon, that was also treating their hepatitis B, notwithstanding the immunomodulatory effect of interferon. That was also, by association, treating their hepatitis B simultaneously, which is not the case for the DAAs, clearly for hepatitis C. Now, I'm going to be referring to this document, which I'm sure has come up through the course of the day and is certainly a good resource. And there's a specific section, the link is there, for treatment of hepatitis C in the setting of hepatitis B co-infection with some consensus recommendations. And so I'll touch on those recommendations through this talk. So as Sam was just really clearly pointing out, in addition to testing for HIV and hepatitis A, it's really important that we test people for hepatitis B once we diagnose an individual with chronic hepatitis C. And that serology really should be that panel of 3 tests: surface antigen, core antibody, and surface antibody. And that allows us not just to think about the management of co-infection, it allows us to think about the potential for reactivation. And it also, very importantly, allows us to vaccinate people if they remain susceptible to hepatitis B, which is a really, really important aspect of care. So indeed, the consensus recommendations do recommend universal screening for hepatitis B for people diagnosed with hepatitis C, and that people should be vaccinated, which is a fairly uncontroversial recommendation, I would suggest. All right, so we've done our panel of 3 tests, and as a consequence, so on the left there is just the decision-making laminate in hepatitis B, which remains ASHM's most popular and most downloaded resource, which I am always satisfied by. But the decision-making in hepatitis B does have a really useful serological interpretation chart on one of the sides, and on the other side obviously has the infamous squiggleogram. But the table of serology here really allows you to just read off and say what the story is. So I guess particularly relevant for co-infection, clearly we want to know if someone has chronic hepatitis B. We also want to know if we need to vaccinate them if they're susceptible. And we also want to know if someone has resolved hepatitis B. But I will come back to that point in a bit more detail. So we've done the testing and we've got a patient who has chronic hepatitis B. They've come up with surface antigen positive. So the next step is again to follow that laminate, to follow that sort of path of care, and to establish whether this individual merits treatment for their hepatitis B in relation to their hepatitis B alone. So we need to do their e antigen status, so e antigen, e antibody, to do a hepatitis B viral load, which is rebatable once per year in all surface antigen positive individuals on the MBS. And also, these are all pretty routine elements of the workup of hepatitis C as well. So you'd be doing your FBE, your liver function tests, etc., to investigate the degree of liver disease. And as has been discussed already today, assessing for the degree of fibrosis. Now, that has particular implications for how we manage co-infection, in addition to the implications it has for the ongoing management of someone living with hepatitis C. So we're trying to establish, does the patient qualify for treatment for Hep B in relation to the Hep B alone? What is the degree of their liver disease? But also, really importantly, again, for hepatitis B, it's important to remember the differences as well. It's much more sexually transmissible than for hepatitis C. The degree of vertical transmission is a lot greater for hepatitis B. And so there are different aspects to the public health management, notification of the health department, and testing and vaccination of household contacts, which are sort of elements that aren't routine in the hepatitis C sort of workup. So if the patient meets criteria for hepatitis B treatment, and in relation to the setting of co-infection, really the consensus guidelines are, if they've got a Hep B DNA greater than 2,000 international units per mil, their ALT will often be elevated, whether that's due to the hepatitis B or to the hepatitis C, but they will meet the criteria for treatment for hepatitis B, particularly if they're e antigen negative. And you can go ahead and treat their hepatitis B. If you're not a hepatitis B section 100 prescriber, then clearly a fantastic resource to pull in would be one of your GP colleagues who is a Hep B section 100 prescriber, or indeed you can ask for an alternative specialist. If you don't have access to a section 100 GP specialist, then an ID physician or gastroenterologist, hepatologist, as appropriate. Also, if someone has cirrhosis, they should be started on treatment. Now, the PBS criteria for that are any detectable Hep B DNA viral load in the setting of cirrhosis. But this is one of the situations we really don't want to see someone flare with their hepatitis B following treatment with DAAs, because a flare of Hep B in someone with cirrhosis can be fatal. And so we really want to make sure they're on antivirals, and ideally they're on their hepatitis B antivirals prior to embarking on the DAA therapy. So Hep B reactivation during and after Hep C treatment is common. It's variably clinically significant. In the trials, often there'd be a viral load uptick. The ALT might waver a bit, but the clinical significance is quite variable. It is most commonly seen in the setting of immune control. So to go back to the hepatitis B sort of natural history, this is people who have a low viral load, they're e antigen negative. And so in this group, it's where we often see the hepatitis, the treatment of Hep C brings the Hep C viral load down, and then their hepatitis B reactivates. I'll come back to the core antibody positive situation, but it's a really important point. The FDA did include some people in the box warning around the direct-acting antivirals who were core antibody positive, surface antigen negative, so past resolved hepatitis B. And that scared a lot of people, because we are talking about a very substantial proportion of people living with hepatitis C who are core antibody positive. If we're thinking about people who inject drugs, then 40 or 50% may be core antibody positive. In the general Australian population, around 15% of people are core antibody positive. So it's a very common finding. What we see, and I'll come back to this point, is really reactivation in that context has only really been described in the setting of significant immunosuppression for other causes. So with the setting of hepatitis B surface antigen positive people, so with chronic Hep B co-infection, if they don't meet the criteria for treatment based on the PBS criteria, and as described above, then the recommendation is they require active monitoring of their ALT and Hep B DNA. Now, this is a problem because on the MBS, you're only allowed to do one viral load, Hep B viral load per annum in someone who's not on treatment for hepatitis B. And so this does introduce barriers to care in the primary care setting, and might be a reason someone needs to be co-managed with a hospital-based clinician, just so that the MBS, so that the monitoring can be done more frequently than once annually, which is really not sufficient. So these are the consensus recommendations, and I'm going to go through these sort of relatively briefly, but just ticking off the points that we've already made as a way to reinforce it. So yes, someone who is co-infected should be managed by a specialist who's experienced in the management of co-infection, and whether that's a GP specialist or a different medical specialist. Patients should have a discussion about the risk of reactivation and what symptoms to look for. So the usual symptoms of a hepatic flare, and to report immediately if they experience those. Everyone who's surface antigen positive should have a Hep B DNA before commencing their DAA therapy to see if they're eligible for treatment. If they are, then they need to be managed as usual with one of the potent, high barrier to resistance antivirals, so essentially entecavir or tenofovir. And ideally that should be commenced before they start their DAA therapy. And really, patients with cirrhosis, it's really important we protect them with hepatitis B treatment, because the flares in that group can indeed be fatal. For non-cirrhotic patients who don't meet the treatment criteria for hepatitis B in their own right, these were the consensus recommendations issued in that document. And you can see here that it includes doing a Hep B DNA every 12 weeks, which is not available on Medicare in the community setting. So really that's where this sort of burden of monitoring really needs to be done in partnership with someone who's got access to hospital-based testing. If their viral load goes above 2,000, then they can be initiated on treatment. And co-infected patients who are already receiving hepatitis B treatment and have suppressed Hep B DNA levels don't appear to be an increased risk of reactivation, because the hepatitis B treatment is actually blocking that from happening, and they can just go on with their regular monitoring and be treated accordingly. So what about the point I raised before about core antibody positive people who are surface antigen negative? And this is a large proportion of people who inject drugs who you may be treating for hepatitis C. So unless they're immunocompromised, the experience is that really the risk of reactivation is negligible, and all the clinical trial data are very reassuring. So the recommendation really is that you only need to do the routine monitoring you would be for someone that you're treating for hepatitis C, and you don't need to do a hepatitis B DNA at baseline for all of these patients. In that setting, it's also not rebatable on Medicare anyway. However, if you're treating someone who's core antibody positive and their ALT either remains elevated or indeed flares whilst you're treating their hepatitis C, you should have a consideration of whether this could be hepatitis B reactivation and investigate it accordingly, both with surface antigen, and obviously if that's positive, then doing a hepatitis B viral load. In the setting of immunocompromise, closer monitoring, including hepatitis B viral load, is necessary. However, again, that is not rebatable on the MBS for people who are surface antigen negative. So that'll need to be done in consultation and partnership with a hospital specialist. So these were the consensus recommendations and the guidelines, that indeed these patients do have a low risk of reactivation unless they're immunosuppressed. The routine path of monitoring should be observed, and that hepatitis B reactivation should be considered in a patient who has a flare, or indeed, if you're treating their hepatitis C and their ALT doesn't budge. And another important thing to consider, along with other causes of liver disease, and I know Sam was discussing the sort of approach to testing for autoimmune liver disease and other causes of liver disease, etc., which is important. So these are the resources that are useful in this setting, particularly the latter of these. So the hepatitis C treatment guidelines, or the consensus statement, which does have a really useful section on co-infection, as does the B positive monograph. So the ASHM resource for managing hepatitis B has got a section on co-infection and immunosuppression as well. And just a final point and a plug, and Nada, I think, would be disappointed if I didn't try and pull one over everybody today. I appreciate the opportunity talking about hepatitis B in this hepatitis C forum. There's another really, really good reason to test people for hepatitis B in a setting of co-infection, and that is that a third of people living with Hep B in Australia have not yet been diagnosed. Nearly 80% are not receiving guideline-based care, and around a third of those who require treatment currently are getting it. So you might think that the care cascade for hepatitis C is pretty woeful. Well, you ain't seen nothing yet. And we are building towards a universal screening platform for hepatitis B in Australia. We've got a paper with the MJA at the moment that hopefully coming out soon, arguing the case for universal screening for adults in hepatitis B in Australia. And really, we need to transform the cascade of care. So if all of you can test all of your hepatitis C patients for hepatitis B, and then take that on and test all the rest of your patients as well, then we'd be doing a great thing for a lot of people living with undiagnosed viral hepatitis. So thank you for the opportunity to talk today, and I'll stop there. Thank you.
Thank you very much, Ben, and also Sam, for presenting in session 5. It's been really great. We've got a couple of questions from the audience. So they're actually both to Ben, but the first one is, could you comment on, from Albert, sorry, could you comment on managing Hep B and Hep C co-infection with elevated ALT discovered on pregnancy first antenatal screening visit?
Yeah, for sure. Look, I'm very happy to start the batting there. I know we've got a lot of other people who can speak to these issues as well, but I'm happy to lead off. So hepatitis B management particularly, it's important to note that there are really two sets of indications for treatment. The first, and clearly the most important, is to look after the health of the mum. So if the woman who's pregnant meets treatment criteria in her own right, then a discussion can be had about initiation of antiviral treatment. There is good evidence that tenofovir is safe in pregnancy, and especially for a woman with advanced liver disease, it is far more important to control that liver disease using a safe antiviral to make sure that she doesn't run into any complications of her liver disease during or following the pregnancy. So that's the most important reason. The second one, of course, is to initiate antiviral therapy as part of the approach to preventing mother-to-child transmission of hepatitis B. And if the mum's viral load is above 200,000 international units, then there is an indication to start antiviral therapy with tenofovir in the third trimester, which significantly further reduces transmission from the mother to child, in addition to the use of the use of vaccine and immune globulin for the neonate. Now, hepatitis C treatment is different because we don't have the same safety data for treatment for hepatitis C during pregnancy, and it doesn't have the same necessity of prevention of mother-to-child transmission. That's a lot lower. If you've got a mum with a high viral load, even with the use of vaccine and immune globulin for the infant, there's around 10% breakthrough if the viral load's really high, whereas the hepatitis C mother-to-child transmission is a lot lower than that. But secondly, the mum can be treated for the hepatitis C after delivering. And if the infant, it's around about a 4% risk of transmission from mother to child with a few variables in there, the infant can always be followed up and treated as once they've gone through childhood, with very, very, very remote chance of the hepatitis C causing any problems for that kid. So really, it's a question of treating the mum once she delivers, but for the hepatitis B, considering treatment both for the mother's health, but also the consideration of mother-child transmission.
Thanks, Ben. There's also another question from Nada that's in the discussion forum.
Yeah, there would be.
Excuse my poor lingo regarding hepatitis B. I'm very much in the hepatitis C world. So
we'll get you, Bianca. We're working with everybody. We'll get you. Don't worry.
Nada, I think I might have missed this, Ben. Sorry, just wondering if you think a 4-weekly LFT during hepatitis C treatment in core antibody positive. I'm not sure what the S antibody negative.
That's okay. I got it. That's fine. So look, Nada, really the recommendations are that doing just the routine monitoring that you would be otherwise is absolutely fine. If we're worried about someone because they've got for instance, advanced liver disease, look, it's not an unreasonable thing to do, but the incidence of reactivation in someone who doesn't have immunosuppression is so low in this sort of a setting, in core antibody positive, surface antigen negative, even if they're surface antibody negative also, it's really low. So essentially, the consensus guidelines state routine monitoring. If they are immunosuppressed, different story, and we need to monitor their viral load and their ALT. And for instance, if it was someone who was surface antigen positive but didn't meet the treatment criteria, we would also want to be monitoring their ALT, and the recommendation is 4 weekly.
Excellent. Thanks, Ben. If there's no further questions from the audience, we might move into the final wrap up for the day. So again, thank you, Ben and Sam, for presenting your presentations. It was really great. So I'll hand over to the General Practitioner Advisory Panel just to give a bit of a wrap up on the themes of the day. Thank you.
Thanks, Bianca. Thanks, Ben. Thanks, Sam. That was super. So we should just sort of summarise the day in probably less than 10 minutes. And I think as a panel, we've decided just to give our 2 minutes of, I guess, learnings of the day that we're take-home messages. But I was hoping that everyone who's still online might be able to contribute to this session as well, just by typing into the discussion forum about maybe 1 or 2 points that they've taken from today that they might, I don't know, implement in their practice or learnings of any kind, just because I think it's been a really great, very, very varied day. And hopefully we can all, I guess, learn from each other. So maybe, Belinda, you can start off by letting us know what you think, I guess, touched you today.
Yep, thanks, Nada. I guess the overall learning for me was that and every time we have these meetings, I come away with the same feeling that it's not really, this elimination is not going to be a technical issue, it's a social one. And like all, social problems, they're not that easy to unpack. And so we're getting very good at developing inventive models for those marginalised and difficult to reach populations. And that seems to be, where there's a lot of advance, but and there's a really good understanding of the barriers in terms of what might be going on with the patient or the clinic level, the doctor. Less so what's going on with the systems is in the big broader systems, but certainly at the clinic level systems, Sam did a really fantastic presentation about what you can do to improve that. But it's really it's more that low prevalence general population cases where you might have just a couple of patients per clinic that we're going to be really struggling with. And so the issue has become one of case finding. And I think that someone touched on that, but we really do need a good awareness campaign, because we need people to come forward themselves, but we also need the clinics to be thinking about how they can do some sort of screening drives on their population base to try and pick out those 2 or 3 patients who might be there. There may be more than that. And I think something that might help that will be looking at how, in what ways GPs can be supported. So I think Ben mentioned a little bit, I don't know if it's along the same lines, but some sort of preventative liver care Medicare item that would give an incentive to GPs to do some general screening without sort of stigmatizing people might be a good idea. And also, we touched on that in the breakout sessions, that Medicare is not really very fit for purpose, so that you'll either have, if it's a complex patient, they may not turn up, and so Medicare is sort of a private business model, so that means that's loss of income for that private business, and so that's a real problem. Or they do turn up, but the consultation is far too long for the 15 minutes that you're given to do it. So we just don't really have the right model Medicare, and what sort of Medicare reform needs to happen to be able to better manage not only hepatitis C, but all these sort of complex social or crossover between social and medical problems that we see. So, some ideas about how to, I think some discussions about how to reform Medicare coming from GPs who're just using this as the model, to the sort of a nut to crack. If you can crack hepatitis C, then perhaps you're going to crack a lot of problems in Medicare. And then lastly, I think also that the roles of the PHN, I was really impressed with some of those audit tools that Sam showed us. I didn't realise that they were around, because the systems we use in the Northern Territory set aside and have their own audit tools, but they look fantastic. So, having assistance with doing those audits to do that case finding, but also beyond that, whether the PHN could have some give more support in helping difficult patients, so sort of a fast track into assistance with social workers or mental health problems, or something to really help you with those more difficult patients, might also help. That's my learnings for the day.
That's awesome, Belinda. Thanks so much. Joss, you're next on my screen.
Fantastic. Yeah, I think sort of take home for me, every year catching up for these forums is fantastic. And every year we're moving further and further closer to the goal of elimination. And every year the conversation keeps moving forward. So that's fantastic and really exciting where we are and where we're heading. I think sort of a couple of things that really sort of stood out for me today was the unique skill sets that GPs have. Not necessarily as doctors, but where they are and how the situation, their model of care is set up, which, as Belinda was sort of alluding to, is one of the weaknesses, but also one of the strengths. So as a GP, you're not necessarily bound by a hospital sort of board and overarching system. So you can be very nimble and you can be very agile and you can sort of, be very versatile in the way that you ply your trade, because you don't need to ask permission from those above. Jonathan going out to a pharmacy, fantastic, example of that. Seema, linking in with, the mental health mob and the emergency department mob and those kind of things, and really get your tentacles out into the community is something I think GPs, obviously do really well, because we're based there. And if you tried to, imagine, do that in a hospital setting, you'd have 15 board meetings, 16 morning teas, and get nowhere in 2.5 months if you're quick. And so that's a really great versatile aspect of general practice. As Belinda was saying, the problem is no one's paying us to do it, but that's okay, I guess, in some regard. But no, it's fantastic. And so I think that's a really exciting thing, is where we are, and being on the ground and being in the community means that as a GP, you can then find out what are the solutions that specific community needs, and rather than thinking about elimination in an Australian front, thinking about elimination on your postcode. And if you can eliminate Hep C in your postcode, you've done your job, and the GP next door does their job, and that's how it's going to happen. And that's really what excites me, is that today we've just seen a whole bunch of people get up and say, this is what I do in my patch. And it's working really well. And this is the unique opportunity. It may not work for you, but it works for me, and take what you can. So, yeah.
That's great. Thanks so much, Joss. And Sam?
Yeah, well, what do I say after those two? Belinda and Joss. So they covered everything, really. I mean, I think there was just a lot of amazing stuff today. And I think the thing that I take home, pretty much as Joss has said, I was just inspired by the individuals that presented today. And, they've clearly gone way above and beyond what is expected of them from the average person. So I just think they're amazing. And it just restores your faith, not only in their ability as clinicians, but just, their humanity, really, and their desire to help these people who are stigmatized and, living with Hep C. So, yeah, it's amazing. And I think there's a lot of amazing clinicians out there in Australia. And that's what's so good about being involved in this each year. You get that little bit of inspiration. So, yeah, I'd like to thank all those people that presented today. And I think they all did an absolutely outstanding job. Thank you.
I completely agree. I think that we're not going to do it by ourselves either as GPs. But and I also really loved the different models of care that were presented today. I think I took away from today also that it's a whole of team approach in general practice. So it starts at the front of house and how accepting your practice might be and how kind your reception staff are and how welcoming your practice, you know, posters might be. So even the simple things that I think I forget might be welcoming are welcoming. I really liked Brian's concept of community-based care for people who are marginalised. So hepatitis C is just one part of their care, and I think that's every patient. You know, for all of us, you know, hepatitis C is just one part of what we do for our patients, and I think that's important to remember. And it might not be the centre of things, but it might be just something to keep that person going if we do treat them. Albert, I thought, was a fantastic presentation as well. He saw a need. and I really like the idea that FibroScan can be a carrot as well, something tactile, something tangible that you can give to the patient at the time that gives them a concept of, yes, this is my liver and yes, this is fine. And I think that was the main thing I got from Joe. Apart from very excited and invigorated, and I just want to go down and, you know, do a little, I guess, audit of my practice yet another one. So, and we do have a comment from Bernadine, and thanks so much for commenting. It is beautiful to know that there are so many professionals like all of you who've presented today who are so passionate about what they do and find satisfaction in their field of work. Oh, and you too, Nada, thank you. That's a very good joke. Bernadine.
Thanks, Nada, for facilitating that part of the day. We all thought that we wouldn't use 10 minutes, but look at us go, we use 11, so well done. So I'm going to indulge everyone in a final wrap up of the day, just to summarize a few things on my end. So I'll just quickly share my screen. Okay, so of course, just wrapping up the day and just touching base on evaluation and some resources that we have available at ASHM. So if you're not already aware, we have the Hepatitis C Community of Practice. Please feel free to join. It's a forum for health professionals working in or interested in hepatitis C. It's moderated by ASHM staff with support of clinical advisors who will post replies to clinical inquiries. We also have this really good resource, Removing Barriers, which addresses stigma and discrimination. And then finally, there's also the website allgood.org.au, which provides resources for BBVs and STIs in a range of languages. And I also ask everyone to sign the pledge. So Aus GPs and Hep C. So we're committed to all GPs in Australia have written a DA script to 20%. And just a little plug on some other ASHM work. So please visit our website. We've got lots of upcoming training. We've got lots of online e-learning that's free to access. Our guidelines, resources, and sector news is available there too. And also, most importantly, so the post-forum evaluation, to evaluate and get feedback on activities, we really rely on participation in our evaluation. So we're all very familiar now with the QR code, so please feel free to scan the QR code. You can also click the link that's in the session information or type in your browser the link that is below. And I think Jane will also be sending out a comms with that link as well later. And finally, a big thank you for everybody, all the presenters that presented today, our wonderful GP advisory panel who advised the program and has facilitated inviting all the speakers, and of course, Gilead and AbbVie for their financial support and supporting the program. And that is all from me. Thank you all and have a lovely Saturday.